All right, let's talk about vascular diseases of the liver. I know, it can be a real headache trying to keep them all straight, but you're in the right place. Today, we're going to break this whole complex topic down into a really simple, high-yield framework, something you can actually use, whether you're on the wards or cramming for boards. So, here's the plan. We're going to take a tour of the liver's plumbing, so to speak. We'll hit 4 key diseases: Budd-Chiari, portal vein thrombosis, sinusoidal obstruction syndrome, and congestive hepatopathy. And by the end of this, I promise, you'll have a super clear way to think about them and tell them apart. All right, let's jump right in. The best way to get a handle on these diseases is to stop thinking about the liver as just, well, an organ. Instead, picture it as a massive, supercritical traffic hub. You've got blood coming in, getting processed, and then heading back out. So what happens when that intricate plumbing fails, right? What happens when these highways get blocked? That's exactly what we're going to explore. We'll look at 4 different traffic jams: a blocked exit ramp, a blocked entrance ramp, a clog on all the tiny local roads inside the liver, and finally, a massive system-wide gridlock that backs everything up. Okay, first up, let's tackle that first scenario, the blocked exit ramp. This is all about what happens when blood can't get out of the liver. And the name for that condition? It's Budd-Chiari syndrome. So you can literally picture this as a major traffic jam right at the liver's exit. Blood is flowing in just fine, but it hits a wall and can't leave through the hepatic veins. And the result? You get this massive congestion, the pressure skyrockets, and if it's not fixed, you're looking at serious liver damage. Now, what causes this jam? Well, if you look at the risk factors, there's a really clear theme: things that make your blood clot way too much. And here's the high-yield tip for your exams, okay? The one association you have to know is with myeloproliferative disorders. They're a classic cause of this kind of hypercoagulable state. And this number, 75%, this points to one of the absolute classic clues you'll see on imaging. In a whopping 3/4 of cases, the caudate lobe of the liver actually gets bigger. So why does that happen? Well, it's pretty cool, actually. The caudate lobe often has its own private drainage system, a little escape route straight to the inferior vena cava. It basically bypasses the main traffic jam. So while the rest of the liver is congested, the caudate is spared and it enlarges to compensate. Seeing that on a CT scan, that's a huge hint. So how do we fix this mess? The game plan is pretty straightforward. First, you've got to deal with the clot itself and prevent new ones from forming. So that means anticoagulation. But that's not enough. You also have to relieve that immense pressure that's built up. Sometimes that means propping the vein open with a stent, or maybe creating a whole new bypass with the procedure called a TIPS. And in the most severe cases, a liver transplant is really the only way out. Okay, so that was the exit ramp. Now let's shift gears and look at the entrance ramp. We just saw what happens when blood can't get out, but what if it can't even get in? Well, that's portal vein thrombosis. Right, so with portal vein thrombosis, or PVT, the traffic jam happens before the blood even reaches the liver's main work areas, the sinusoids. The portal vein, that's the big highway bringing all the blood from your gut, it's blocked by a clot. Simple as that. And when you look at the risk factors, you'll see some familiar faces. Yep, those hypercoagulable states are back again. But here's the key difference. For PVT, you really have to think about local problems. Cirrhosis is a huge one, but so are things happening right next door, like pancreatitis or recent abdominal surgery. Anything that can directly mess with the portal vein is a suspect. And the treatment plan flows directly from that. Of course, you're going to use anticoagulation to try and get rid of the clot and stop it from growing, but, and this is super important, because the blood is backing up before it gets to the liver, all that pressure builds up in the veins of the esophagus and stomach. We call those varices, and they can bleed, which is a major emergency. So finding and managing those varices is an absolute top priority. Okay, so we've covered the main highways in and out of the liver. Now, let's zoom way in. Let's go deep inside, down to the microscopic level. What happens when it's not the big highways, but all the tiny little local roads that get clogged up at the same time? Well, that is sinusoidal obstruction syndrome. Yeah, this is a totally different beast. We're not talking about one big clot in a big vessel anymore. Instead, this is a toxic injury to the delicate lining of the liver's tiniest blood vessels, the sinusoids. And that injury causes widespread microscopic blockage and damage. You might have heard of it by its old name, veno-occlusive disease, or VOD. And the classic story, the one to remember for your tests, is a patient who just had a stem cell transplant. And speaking of tests, these diagnostic criteria are about as high yield as it gets. So picture this. You have a patient, they just had a stem cell transplant a week or 2 ago. Suddenly, their bilirubin starts to climb. And you also notice at least 2 of these 3 things. Their liver is getting bigger and it's painful, they're developing new ascites, or they're gaining weight really fast from fluid retention. If you see that picture, alarm bells for SOS should be going off in your head. And when it comes to treatment, besides just supporting the patient, there's really one key medication you need to know for severe SOS, and that's defibrotide. It's the main drug that's actually been shown to improve outcomes. Okay, let's take a step back. So far, every problem we've talked about has started either inside the liver or right next to it. Before our last one, we need to zoom all the way out. What happens when the problem isn't in the liver at all? What if a problem somewhere else in the body causes a massive system-wide traffic backup? That, my friends, is congestive hepatopathy. With this one, the liver is basically an innocent bystander. Its plumbing is totally fine. The exit ramps are clear, the entrance ramps are clear, all the local roads are clear. The problem is the main drain that the whole system empties into is blocked. We're talking about a failing right side of the heart. If the heart can't pump the blood forward, it can't accept the blood coming out of the liver, so everything just backs up. It causes this passive congestion. And this is the whole point, really. All the clues you find point away from a primary liver problem. On imaging, you see the backup in the big veins leading to the heart. The liver labs are often only mildly elevated, and that leads to the biggest takeaway of all. The solution isn't in the liver. You have to treat the underlying heart failure. You fix the system-wide gridlock, and only then will the liver's congestion get better. All right, that was a lot, I know. We've just gone through 4 really different ways the liver's blood flow can get messed up. So let's pull it all together now into one single framework, just to make sure it all sticks in your brain. Okay, this slide right here, this is your money slide, your high-yield summary. Just look at how simple it is. If you just ask yourself, where is the traffic jam? The answer points you right to the diagnosis. Is the outflow blocked? You're thinking Budd-Chiari, and you're looking for that caudate hypertrophy. Is the inflow blocked? That's PVT, and you're thinking about local causes like cirrhosis. Is it the tiny microvessels? That's SOS, especially after a transplant. And if it's a huge systemic backflow, that's congestive hepatopathy from a failing heart. See, it's a beautiful framework. So here's the bottom line. The next time you're on the wards and you see a patient with new ascites or their liver tests are all over the place and you don't know why, I want you to pull out this mental map. Ask yourself, is this an exit ramp problem, an entrance ramp problem, a local roads problem, or a system-wide gridlock? Because using that simple anatomical framework, that's how you go from just memorizing facts to actually making a tough diagnosis at the bedside.